Thank you, everybody. So I have the real privilege here of bringing together a group of folks that at Ember we've been interacting for a while, but we realized had the unique opportunity here to help talk more about not a single practice, but kind of a consortium that's been building around what the real world of this practice looks like. You all have heard a lot of real world data over the last couple of days. We're going to have the chance for each of the four presenters to come up and talk about kind of a subset of the field, about what we're seeing out in clinical practice. And as a good segue from the presentation you just heard, one of the things that we're going to be focusing on is about some of the safety data we have, and kind of what we can see from that, what are the real risks, and what are the things that are coming up in an actual practical day-to-day. So with that, Dr. Benjamin Way is going to come up and take us off.
Hi, everyone. Today I'm going to be talking about acute symptom response to IV ketamine in major depressive and bipolar depression. It goes without saying for an audience like this, but we know that major depressive disorder, MDD, and bipolar disorder are highly prevalent, with MDD being a leading cause of disability worldwide and bipolar disorder affecting about 40 million individuals around the world. However, despite this, and as we learned from the STAR-D trial a number of years ago, an estimated 30% of patients will remain non-responsive to consecutive first-line treatments and eventually go on to meet criteria for treatment-resistant depression. And even if successful, the onset of effects for many of these first-line treatments can take many weeks to months to take hold. And this, of course, in the past 20 years or so has led to a real surge in the interest in characterizing ketamine as a rapidly acting antidepressant, not only for MDD, but also for BD. However, most evidence in support of ketamine's antidepressant effects have historically stemmed from small and more tightly controlled clinical trials, and this has left us with more limited evidence from real-world settings where patients might present with more heterogeneous symptom profiles as well as various medication histories. So this motivated us to investigate two primary aims here. The first was to characterize the trajectory of symptoms in a large real-world patient cohort of ketamine receivers. And secondly, we wanted to identify whether certain patient factors, including primary diagnosis or comorbid diagnoses, as well as demographic factors, would moderate the trajectory of symptom recovery over the course of treatment. And so this was in collaboration with Nico at Ember Health. This was a retrospective study using data from his 5 clinics in the greater New York area. These were all adult patients receiving IV ketamine to treat MDD or BD between early 2019 and mid-2025. The patients were recommended to follow a standardized workflow of about 4 infusions over 14 days, with dosing ranging from 0.5 to 1 mg per kg. And this is an overview of the patient cohort. As you can see, there were 2,097 patients with repeated assessments across I should say before, during, and after treatment, amounting to close to 12,000 PHQ assessments over that time horizon. You can see that there were 214 patients with a primary diagnosis of bipolar disorder, and the remainder being about 1,900 with a primary diagnosis of MDD. The patients self-reported a number of comorbid disorders, including anxiety disorder, OCD, PTSD, and substance use disorder. We also included a flag for patients who scored above 0 on the 9th item of the PHQ-9 to indicate the presence of suicidal ideation. And you can also see that there were a number of between-group differences between those with MDD and BD. For instance, those in the MDD group were significantly older, only by about 2 years. There was a higher prevalence of anxiety disorder in that group, and they started and ended treatment with slightly lower symptom burden. So to approach this, we used linear mixed effects models to model the trajectory of the PHQ-9 total score across repeated measures of these subjects. The time points included a baseline assessment that occurred within 30 days of the first infusion. There were multiple assessments during the treatment course, typically occurring on visits number 1 and 4. And there were multiple time points included after the completion of the infusion series. We capped this at 30 days after the final infusion, but excluded any periods of maintenance treatment. We encoded time in these models as the time since, the days I should say, since the first infusion. We decided to log transform this to account for the observation that there was a more rapid early reduction in symptoms, which sort of tapered off and gave us diminishing returns towards the end of treatment. All of these models adjusted for things like baseline symptom severity, demographics including age and sex, primary and comorbid diagnoses, concurrent medication classes, and protocol completion. All the multiple comparisons within these models were adjusted using the FDR approach. For AIM-1, we simply fit a linear mixed effects model with only main effects, just to examine the average change in symptoms over time. We had a second model fit using time by factor terms to examine directly whether or not things like primary diagnosis and comorbidities would affect symptom trajectories. So jumping right into the results of AIM-1, looking at the main effects. Here on the left, we're just showing the model predicted trajectories of symptoms over the course of treatment. So predicted symptoms on the y-axis, days since first infusion on the x. You can see on the right that the majority of these patients, 87%, adhered to a recommended treatment protocol of 4 infusions over 14 days. And of the completers, remission was achieved by 40%, response in 68%, and a clinically meaningful improvement marked by at least a 5-point improvement on the PHQ by 78% of patients. Time was a significant main effect, meaning that depressive symptoms were significantly reduced over time. This was a large effect size with a partial eta squared of about 0.47. For primary diagnosis, we observed no significant difference in average symptom burden across the time horizon that we looked at. But there were a number of other significant main effects. For instance, we saw that among OCD patients, males and seniors aged 65 and up, there was a higher average symptom burden. Moving on to AIM-2, this is looking at whether or not certain factors moderate the trajectory of symptoms. These are the same sorts of plots with predicted PHQ-9 scores on the y-axis and days since the first infusion on the x, this time stratified by the factor of interest, which here is primary diagnosis. You can see that there's actually no difference in trajectories between those with BD and MDD. However, among the self-reported comorbidities, we did observe significant differences in trajectories. So just for reference, in each of these panels, the blue line refers to the subset of patients with the presence of the given comorbidity. So you can see that those who endorsed suicidal ideation, PTSD, or SUD all had accelerated rates of improvement. Meanwhile, in the bottom left, you can see that those who had OCD had a more attenuated rate of improvement. And I should say, importantly, we did conduct within group analyses for each of these subgroups of patients, and each did have a significant main effective time, meaning that treatment was effective despite these between group differences. On the basis of demographics, we stratified patients into adults between the age of 18 and 64 and seniors age 65 and up. And you can see that the rate of improvement was significantly slower in seniors relative to adults. We also saw that males relative to females exhibited a trend level reduction in the rate of their recovery. But again, just like the previous slide, within group effects showed that ketamine was still effective within each of these subgroups. So just some take-home points here. On this large real-world outpatient cohort, we observed robust and rapid reductions in depressive symptoms following a standardized initiation series. The effect size for this reduction was large and fairly comparable to what we've seen in a lot of controlled trials. And 4 out of 5 patients achieved a clinically meaningful amount of symptom reduction. We saw no significant effects, either as a main effect or an interaction with time on the basis of primary diagnosis, and this seems to suggest that at least in this cohort, IV ketamine is effective for both those with MDD and BD. There were some interesting differences that we saw on the basis of comorbidities. We saw that those with PTSD, substance use disorder, or some level of suicidal ideation may have accelerated improvement. Conversely, we saw that elderly patients or those with OCD had more attenuated or slower responses, but even still, within group analyses showed that it was still effective for these groups. So with that, I'll pass it on to the next, and thank you. I'll be happy to take questions later.
Hi, everyone. Just going to take a minute to make sure my slides get loaded. Oh, sorry, my phone. Oh, wow, look at that. All right, so hi, everyone. I'm Brittany O'Brien. Thank you all for being here, and thank you to Nico for organizing this and inviting me to participate. So I'm going to be talking about the acute and sustained antisuicidal effects of IV ketamine. And some findings that I am happy to share with you about an analysis we recently did in a real-world sample. Okay. So I have no disclosures. I guess we're skipping that slide, but okay. So I'm going to do a quick review of some literature on this topic. We know that ketamine can have rapid antisuicidal effects for depressed patients endorsing SI pretreatment. This figure is from Ballard's 2014 paper and illustrates those effects across 4 randomized controlled trials and 133 patients comparing after a single infusion of ketamine versus 1 infusion of midazolam. These studies collectively suggested that these benefits maintained for patients for 3 days. A few years later, in 2018, Wilkinson's meta-analysis of 10 RCTs, including 167 patients with baseline SI, observed that the antisuicidal effects of 1 infusion could actually last up to 1 week. But what about repeated infusions, right? That's what we normally see in the real world anyway. In 2020, McIntyre's group evaluated this with a retrospective analysis of 190 real-world patients with TRD, both unipolar and bipolar, and these folks received a series of 4 infusions. As you can see from the figure here, their findings suggested that there was both an additional antidepressant and antisuicidal benefit from repeated infusions. However, what we don't know from this study is really truly how much of a cumulative effect there was and really much about the durability of this course of treatment. Another retrospective analysis of real-world data was published by Calabresi around the same time. This data came from her own practice and 133 patients who received a series of 6 IV ketamine infusions. Her findings also suggested a cumulative effect from repeated infusions, with almost 80% of patients who had baseline SI showing a reduction of SI after 5 infusions. For almost 60% of the patients in this sample, their SI resolved completely. So these studies taken together suggest a cumulative antisuicidal effect. And extending what we do know from ketamine's antidepressant effects, repeated infusions seem to prolong the benefit. Whether or how much that's true for its antisuicidal effects remains unclear. So last year, and here, I presented on what published evidence we have so far on ketamine and its antisuicidal effects. The gaps that we identified in the literature with significant clinical implications for patients and their providers related to dose and durability. What is the optimal dose for treating SI? And what is the durability of a repeated course of infusions? This past summer, a research intern in our group, Margot Cades, decided to focus on this durability question. She and I partnered with another ASKP3 member, Dr. Tiago Gil from Brazil, to analyze his patient outcomes data over the span of 3 months of treatment. The sample was 150 patients who received IV ketamine and completed PHQ-9s before each treatment. 2/3 of the sample had at least some initial SI at baseline, and almost half had moderate to severe SI at baseline. The breakdown of the severity of SI from the PHQ-9 item 9 and its changes over time are illustrated in the figure on the left here. Red is bad, meaning severe SI. Green is good, meaning no SI. Oh, no, I'm still on the right slide. Oh, no. Okay, thank you, sorry. Oh, is this like one ahead or something? No? All right, hold on. Okay, sorry. Okay, so hopefully we're on the same page. All right. Using a linear mixed effects model, Margot found a significant effect of time on SI over the course of 3 months. Not only was there a significant reduction after the first infusion, and consistent with the other studies that we reviewed, there was also a cumulative increasing benefit from a series of 4 infusions. When we compare their suicidal ideation at 1 month post-baseline to the other time points, this 1-month assessment was completed when patients had returned to the clinic and were about to receive another infusion. And I emphasize this because that means this data is coming from patients who are continuing into the maintenance phase of treatment. There was no significant difference between their previous infusion SI score and their 1-month pre-infusion SI score. So this would suggest that they maintained those gains. Further, there was no significant difference between their 1-month pre-infusion SI score and their 3-month pre-infusion SI score, also suggesting a maintained benefit. Okay. So we decided to try and replicate this in a larger, unique sample of patients, because when you find something once, that's fun, but if you want to have confidence it's a real finding, and especially if you don't have a randomized controlled design, it's always best to replicate. So the aim of our current study really was to examine the acute and sustained antisuicidal benefit of IV ketamine treatment in a large community clinic sample. Our questions were, how prevalent is SI at baseline among real-world patients seeking IV ketamine? Are the antisuicidal effects and benefit of IV ketamine cumulative? Do these effects maintain after 1 month and after 3 months? Our hypotheses were that we'd see a significant acute reduction of SI after the first infusion, and with continued treatment, SI will continue to decrease. Finally, that reductions to SI observed at 1 month post first infusion will be maintained at 3 months. We partnered with a local to me, Houston-based IV ketamine clinic to evaluate their patient outcomes over the span of a 3-month period. The sample size was 500, and we used item 12 on the QIDS-SR as the outcome measure. We assessed the patient's responses to item 12 at 6 time points, and QIDS were completed at a clinic visit prior to the scheduled infusion. Here's what we found. Pertaining to question 1, how many patients showed up with baseline SI? A whopping 2/3 of them did, okay? And of those patients with baseline SI, almost half were endorsing moderate to severe SI. We ran a linear mixed effects model and found a significant reduction of SI over time. A significant reduction occurred after a single infusion, and continued improvement over the acute course of treatment was also found. There was a significant difference between baseline and at the 1 month post first infusion, and also between baseline and 3 months after the first infusion. And these improvements remain significant even when controlling for sex, age, and baseline SI. In terms of our questions about the cumulative effect, it indeed appeared that the effects were cumulative over the acute course, but there wasn't at least a significant difference in SI after the second and third infusions. To help break this down, and I'm almost done, here are the pairwise comparison of the QIDS item 12 scores between all the assessed time points. As you can see highlighted in yellow, those are the non-significant differences, both between a 3rd and 4th clinic visits, and also between the 1 and 3 month clinic visits. And what we can potentially draw from this is that the antisuicidal benefit at 1 month was unchanged and therefore maintained at 3 months. Of course, this is not without several caveats, including, most importantly, that the data was, again, collected not as a pure follow-up assessment as you would in an RCT, but this comes from data that we're collecting from patients who are still receiving maintenance treatment. Our limitations obviously, this is a naturalistic cohort of clinic patients. It's open label. It's a symptom-driven treatment, right? Patients are coming back when they're not feeling well. We did not adjust for total number of infusions or the dosages of these infusions. And we also didn't include the sample's demographic and clinical details, including diagnosis, education level, SES, all those things that we would normally in a larger sort of analysis. So our conclusions and our answers to our questions, right? In a real-world community clinic sample, the majority of patients seeking IV ketamine treatment reported the presence and significant improvements to SI after both a single and repeated infusions. Further improvements to SI at 1 month were maintained at up to 3 months. So IV ketamine treatment may produce rapid and durable improvements to SI, though specific treatment protocols in terms of dose and frequency remains unclear for how to accomplish this with the maintenance phase of treatment. Our next steps would be to adjust for dosage and total number of infusions, how to better understand how to optimize dosing, and to optimize sort of treatment number and frequency. We'd also really like to evaluate the potential of concurrent adjunctive treatments, such as psychotherapy, to enhance and prolong SI improvements. And we also really just need more clinical trials with controlled designs for patients with actual acute suicide risk, and not exclude these patients just because they have active SI. Thank you to the clinic that gave me their data, Wells Medicine, also Margot, and our other research intern, Akshara. All right.
Okay. So we just heard two powerful examples of what treatment outcomes can look like for patients in the real world, both in terms of the antidepressant effect as well as the antisuicidal effect. One of the things as a clinician that I'm always conscious of is that all conversations really should be about the risks and the benefits, and so you need to know the risks of what these treatments are like. So what we were able to do at our practice over the last, call it, year and a half for this study was start to look at those risks and actually put some numbers to them. So you've seen this before, but as a reminder, ketamine is a very safe medication. Ketamine is not a perfectly safe medication. This was a decent review 2 years ago now, and it included both IV ketamine as well as Spravato. So as a point of clarity here, the adverse events that they're recording in this are from both of those drugs combined. And this is talking about the medically significant adverse events, as well as the kind of things that you would consider life-threatening. So FDA has a formal definition of what they consider a medically significant adverse event, or a serious adverse event. And those are not things like getting nauseous. Those are things like apnea. If a clinician didn't intervene, you're going to have a loss of life. And they were showing that 0.1% of the time, for those receiving treatment, there were these types of events that could have led to loss of life if there had not been an intervention by the clinical team present. That's a roughly 1 in 1,000 chance of one of those things happening. How you classify medical adverse events is a range, and a lot of you know this just from your day-to-day practice, but there are these more mild events, nausea, headache. If you're doing this IV, the IV infiltrating, those are common things to have come up. They don't usually have dangerous consequences. They often don't even necessarily stop the treatment process. The ones in the middle here are the ones where it is very context dependent. You may have to stop an infusion if somebody is throwing up too much. Depending on the degree of tachycardia or hypertension, similarly, you may actually have to intervene and do things. And then the stuff on the right is kind of ubiquitously defined as things that you would stop, care for, stabilize, and ensure there's no further repercussions from that. I think most of the group has heard this before, but these low but non-zero risks are one of the reasons that the FDA has put out formal guidance in this space. This was published in October of 23. And part of the warning the FDA put out for the ketamine space more broadly is a warning against having ketamine outside of the monitoring of a healthcare professional. This has been a bit of debate in the field, but it is a stance that is public. It is a stance that we need to be aware of as you think about your own clinical practice, because this stance is not an opinion. This is a statement the FDA has made, and it will be brought up if any issues come up as to why healthcare professionals weren't present given these risks. As you all have heard, because of some of these safety concerns, our practice has one-to-one care. There is a clinician monitoring a patient at all times. So these are situations where the patient is never left alone. That does have a couple of benefits that we can be quite specific about. So we are able to do full cardiorespiratory monitoring for our patients, should we need to do so. Each of our sites, despite looking like that, are able to pull out a monitor or have a monitor at the baseline to be able to make sure heart rate, blood pressure are okay. Our practice has standard operating procedures as well as rescue medications for all of the side effects that you should theoretically see with ketamine. So all the things we just listed, there is a policy and a step-by-step for what we do in each of those cases. And then we also have ambu bags and AEDs in office just in case, to make sure. One thing to highlight before I go one step further, given how rare adverse events are, but given that they do happen statistically, you really do have to take an orientation that treat enough people, one of these things is likely to happen. And particularly for some of those types of events, you're not going to get self-reports about the events. It would be an unusual situation for something bad to happen in a non-observed setting, and then for you to guarantee that you're going to know about each and every one of those, given that they're pretty unlikely to begin with. So one of the benefits of running something like what we're about to talk about is that we were witness to every single treatment that we did, and we have a clinician reporting that, yes, that went safely, or no, something came up, with what should essentially be 100% accuracy, given that we were there. And so we don't have any lost records. So what do we want to do with this study? This was a review of every single visit that we conducted over this time frame. So it was 32,000 infusions, the medical records provided by the clinicians who were present in the room. It was basically 2,200 something unique patients. And then we're able to track both visit level adverse events, so like what happened during the session, and then we're able to aggregate that to patient level adverse events. How likely is this per person? And as you've seen, we have pretty conservative safety definitions for how to handle these. Our EHR allows us to flag anytime something comes up. And then we also have free text fields that can click much deeper about what we did about those events when a situation occurs. I added a dose slide here at the last minute because it's been brought up a bunch as questions. And this also helps set the frame for the fact that these events that we're about to talk about occur at what some people in this room would consider low doses. So quickly running through this, in our initiation series, we escalate based on how symptoms have been responding. Said differently, if a patient starts doing well, we stop going up. And if they haven't yet started to do well, we continue to go up. We always work within a frame of 0.5 to 1.0. You can see the total mean ketamine dose for the first 4 visits is 0.6 mg per kg. I believe that's relatively low compared to some people in the room, even though that's where we land for symptom response for most of our people. When you look at all of the infusions, our average dose is 0.67. So again, relatively in the middle of the range that a lot of people talk about. Highlighted for clarity there. What did we see? So most sessions, nothing happened. 95% of the time, patients sat there quietly and comfortably. No clinical intervention, no physician or nurse intervention. As you saw from those of you who were in Chrissy's presentation yesterday, about 3% of the time-ish, there was a psychological event, behavioral event, something that the person in the room considered to not be not medical, but much more due to the altered state. Medical events occurred in roughly 1% of our visits, and then fraction of a percent had this situation where it was probably behavioral and medical combined. Most common of those would be anxiety and tachycardia as a situation where those are probably going to be linked. What we're about to dive into is where the medical events occurred. So of those percent-ish of situations, what did the clinician have to do? Oh, go back. We ended up giving medications in roughly 1 in 100 visits. So a physician had to act, had to intervene, had to give something to resolve the situation as an active intervention in the process. There were, of the visits that had a medical event, a number of events that didn't need an intervention. So we were there, we assessed the person, but decided that nothing else needed to be done. For a small fraction of these, we had to stop the infusion. And that happened roughly 1 in every 1,700 visits, where we decided you shouldn't go further. Oh, sorry, there's a typo. First thing that says stopped infusion is supposed to say paused infusion. Second thing that says stopped infusion is we actually stopped it and it stayed stopped during the course of this. So that was only 30 or so times, but nevertheless, these were situations where it was felt to be dangerous to the individual if we were to continue providing care over the course of this. Similar to the survey you just saw, we have at our practice not needed to use those ambu bags or the AEDs, although as you saw from the survey, that's not unheard of in the community. So there is a difference when you think about this work between a likelihood of something happening in an office during a visit and the likelihood of it happening to a patient. This makes sense. Patients have more than one visit. So as you stack those visits, you should see different outcomes for the individuals going through care. So in our practice, 85%, 84% of patients have never had anything medical come up during this, most. But for 1 out of 10 of our patients, they've had a visit where we felt the clinician has to intervene and give them medication during the treatment itself for their safety and well-being. About 3% of our patients have had the infusion stopped. And about 2.5% of our patients have had the infusion paused. We were able to stabilize. We were able to continue in that situation. This is specifically for medical events. Again, we had a different presentation about the psychological events, but they're roughly similar frameworks there. What were those medical events? So the most common one, to no one's surprise, was nausea. And to repeat, this was nausea that rose to the level that the clinician felt they had to actively intervene. So it wasn't that 0.4% of our infusions people became nauseous. It was that 0.4% of the time nausea was so bad that we felt we had to act, that we had to do something. Patient was saying, I can't keep going. Patient was expressing distress. Tachycardia was another common one. Again, the rate of tachycardia is much higher than this. This is a situation where the tachycardia warranted the clinician assessment and intervention. Frank emesis, and then other is the part we'll click on in a second here. When these events occurred, what were those medications we gave? Diemetics, again, no surprise, the most common thing. Beta blockers, which were predominantly used in the tachycardic hypertensive situations. There's some indication for anxiety here because, again, some of these were these combo events of the person was having panic and was tachycardic, so it got flagged for both. And then benzodiazepines we gave 9 visits amongst 8 patients. Now, if you flip this, again, patients, about 7% of them are going to have active intervention for antiemetics. About 3% of them are going to have active intervention for beta blockers, and about 0.4% of them are going to have active intervention for benzos. This has to be taken in the context of pre-treatment. So we are in office. We have doctors present, and we can help patients try to get through this whole process in a way in a pre-medication. About a third of our visits, not patients, third of visits involve giving Zofran beforehand. This tends to be as a reaction to a prior session where nausea came up. We try to help pre-medicate them to get through that. Very rare, but common enough practice for us to be able to give propranolol in advance. That's usually a pre-medication for anxiety. Tylenol comes up often enough for people who have known headache reactions to this. And then there were these 4 situations for people with prior extreme panic or extreme reactions where they were pre-medicated with midazolam before treatment. Given the time, I'm going to go pretty quickly through these last 2. So what we saw that for the Zofran specifically, there's a funny thing here where people who got Zofran were slightly more likely to report nausea after the fact at the end of the session. That makes sense in that we're only giving Zofran to people who have previously expressed nausea from this process. So please don't interpret this as Zofran causes nausea. Interpret this as even when you give Zofran to people, they're still going to get pretty nauseous. And it only is sort of effective for what we do. This is, I think, the meat and potatoes of this slide, of the presentation. We have seen essentially 20 situations where we were concerned enough that we would define this situation as one that could have led to loss of life or morbidity for the individual. So several episodes of hypoxia, several episodes of tachypnea, palpitations would have been situations where we had to assess for things like MI, chest pain, is this a cardiac event, et cetera. Frank dyspnea, significant hypotension, an arrhythmia that started in the middle of this, persistent hypertension, despite medication and stopping the pump, as well as a combo event. That means for us, for these 32,000 visits, we're seeing that roughly per visit, a 0.6% medically significant adverse event rate. And when you look at it at a per patient level, just shy of 1% of patients would eventually qualify as having a medically significant adverse event under the treatment of IV ketamine. We've had 6 situations where patients were sent to the ER. I want to emphasize this. We're staffed by ER doctors. So our docs on site are emergency medicine physicians, and 6 of the time we still felt they needed to do something beyond what we could do in that office and escalate them. And very thankfully, with all of these interventions, despite the seriousness of some of these situations, we are not aware of any treatment-emergent deaths or any cases of lasting harm. We have ridiculously extensive follow-up with our patients, but nothing that recurred as a consequence of treatment that we're aware of because of the interventions that we had. So with that, thank you. I'm going to give it over to Mike for the last part of this.
Testing. Y'all hear me? All right. All right, so now for something completely different. So, escalated IV ketamine. So there's been a lot of talk about, how to get folks in the mindset of experiencing ketamine and having the best outcome, soothing environments, one-to-one coverage. So we don't have anything like that at MGH, right? So I'll give you basically a background of the clinic. It's definitely prioritizing access and volume over experience. So I'm open for lots of questions and discussions about this. So basically we've got 9 beds separated by curtains surrounding a nurses and staff station where the clinician hangs out. And basically we have 2-hour time slots from 8 a.m. till 7 p.m. or so, and we basically fill up 9 beds every 2 hours, treating about up to 45 people a day, 175 different people a week, and 600 or so active patients any given time. And so we want to keep folks comfortable and enjoy the experience. We do lots of counseling on working with their providers outside to help them have any kind of cap, asynchronous cap that they would like. And the name of the game is getting people to respond to treatment. So we'll start with that. All right, so just like it's been mentioned a few times here, we do an escalated dose. It's 2 treatments a week for 3 weeks, and we start at 0.5, and as tolerated, we'll increase it to 1, and then space out to weekly, increasing as needed and tolerated. If anyone at any time responds really well, we'll just stop increasing it, but that doesn't seem to be the case in our patient population. So demographics, generally very similar to what Nico and others have presented. Basically, MDD, BP, multiple medical and psychiatric comorbidities, failed at least 4 antidepressants, usually what insurance needs to cover it, or out of pocket. Really, the first few years were out of pocket, and now we've got 2 large insurance payers covering it, as well as one of them does Mass Health Medicaid, and so we have a variety of patients at this point. Maybe 3/4 have insurance paying for it. Failed multiple interventions, including everything you'd expect, TMS, ECT. They have to have a primary psychiatric prescriber, so we have very few that have PCP or therapy. They have to have a psychiatrist or NP. No active substance use disorder, no psychosis, nothing that can come in, just like lots of folks. We do, yes it is. With substance use, it can't be active. We'd like to see them in early remission at a minimum, a month to 3 months. We are familiar with the data that ketamine probably prevents relapse, and we have seen that play out multiple times in just about every substance use disorder that exists. Some demographics, basically similar to what everyone else has presented, age 42, majority female. We do have a relatively large transgender population, mostly white, non-Hispanic. Importantly, the quick inventory depression is what we've been using since 2018, and we take it on the day of service. So you come in, you give your quids, you get treatment, so that whatever the interval has been between the treatments, the quids is basically read on the time in which you feel like you need another treatment, or the clinician, you have like designated this is time for another treatment. So it's the illest you've been in the interval, of course, and as you know, people get better for a day or two, like remarkably better for a few days, and then slowly drift back to relapse or symptom recurrence. Our average is like 16.4 at presentation. Generally, this is our population. 50% of a diagnosis of generalized anxiety disorder, 35% of active PTSD symptoms, and about 50% have a diagnosis of PTSD, and about 70 to 80% or so have a traumatic event that could possibly be related to complex PTSD, et cetera. Panic disorder, you see 23%. OCD 14, that seems a little low. History of substance use 50%. That's any substance use, but it's had to be treated at some point. So they're not just like they use alcohol like anyone does socially, but has to be had at some point in life caused a problem. 50% have concurrent psychotherapy. 22% have non-suicidal self-injurious behavior. About 4 lifetime inpatient hospitalizations. Partial programs, 20% failing ECT, 20% failing TMS, 44% of a major medical condition. So these are folks with a history of a stroke, heart failure, COPD, chronic kidney disease, Crohn's, GERD. 12% have diagnosed OSA, and chronic pain population as well. So I don't know how that compares to everybody else's generally, but we tend to get patients that are referred internally when they're too ill. And particularly from the community, when no other places in the area will treat them, they come to Mass General Hospital. Okay. People asked before, are these failures due to intolerance or adequate medication failures? So we've got 40% of our patients have 9 or more trials in their life, and a lot of them are sufficient and adequate trials. Our patient population is on average, they have 50% of their life spent with depression. So if they're, I think the oldest person at like a 90-year or so, 90% of his life at like 85 years old was spent with depression. And then of course we've got a variety of young population and even adolescents that have spent about 50% of their lives depressed. So generally speaking, like I said, about a 16.5 average QID score at presentation. Then after 6 visits, this will be presenting for the 6th visit, not 6 infusions with this data right here. But you can see there's a shift of the average, down to about 11. And overlaid, you can see that even just within 5 treatments over 2 weeks, and the 6th one coming in for the score essay, there's a significant shift down when they're overlaid. Okay. And so just some characteristics of our clinics. We've treated, basically, you can see here about 300 to 400 people had at least 6 treatments, and there are about 50 people that have had over 40 treatments at the time of this sample that I'm going to give the data from right now. The dosing is escalated and is tolerated, so you can see that we get about 1.2, 1.3 mg per kg for most people. I think our median is about 1.3, 1.4. But we do go much higher, and on average, by the time someone's had 30 treatments, they're at about 1.5, with a significant amount of people closer to the 2 milligram range. And then here is where there may be a difference from the crowd and the panel. So we have taken the stance that adverse events, mild adverse events, are pesky side effects that need to be managed to facilitate tolerance. So just like many of your experiences, sure with your patients by like the 3rd or 4th dose, 0.75, 0.8 mg per kg maybe, they start to not tolerate it very well. And anyone who even gets nauseous from the first visit will get Zofran every time from then on. So that leads to about 90% of people getting some degree of Zofran. A lot of them also get Compazine. They will not get Compazine unless they've already had Zofran, and they may get them both at the same time. Unless there's an intolerance or a long QT reason not to get Zofran and just get the Compazine, but it is mostly by far both. And then benzodiazepines is one. Once again, basically all of our patients, 86%, get at least 0.25 milligrams of Ativan, and as we go up on the dose and they start to have more psychological challenges with it, they get more, maxing out around 2 milligrams, which leads to like a variety of experiences, mostly very relaxed and not nearly as intense of a psychological experience. So patients like it, they prefer it, they ask for it. We often use Ativan to facilitate the tolerance of much higher doses. Frequently, if someone is almost like, having a panic attack at 0.7, you give half a milligram of Ativan and then they tolerate to 1.5 mg per kg and they get a lot better. Additionally, we treat folks with hypertension. Lots of them have hypertension. Even if it's well controlled, they still seem to spike BP. We do not like to see BP go over 175, 180. So certainly when it starts to approach that at like the 20-minute mark, they'll be monitored every 5 minutes, and if it keeps going up, they'll get like 2.5 of labetalol, and based on how high it goes, we keep giving labetalol, and then we just pre-treat from then on, and we'll still continue to increase the dose if it doesn't doesn't cause any potential hypertensive issue. Obviously, people have headaches like we just talked about. And then the results of the data is basically by like the 20th treatment, these folks have an interval of around 20 days. So it's a U-shaped curve, not because of our dosing, but mostly because we don't have that many patients going out to 80 treatments at the time of this sample, so they're more ill. So even if they're getting 1.8 mg per kg, they're still not responding, still not coming less frequently than every 2 weeks. So basically, our approach leads to very similar outcomes that everybody else has, and I don't know if it's our population, is why we've gotten accustomed to doing this, but they still seem to respond at similar rates for similar durations. Overall, I tried to keep this very simple with some of the scores from our quiz, some of the subscales, but basically what you can see there is by about, by treatment number 10, it looks like everyone is leveled off on average. So regardless of the number of treatments someone has had or how ill they are or their comorbidities, basically people come for treatment when they can't tolerate their symptoms, right? So on average, people come with about 11, and that's the most that our folks can tolerate. And so regardless of the interval, like I said, by 20 or 30, you're coming every 2 to 3 weeks, you're still coming at about a quids of 10.5. Interestingly enough, just like Brittany mentioned, there's SI continues to get better over time, and basically the only ones where you have a spike up at the end is when these are people who are chronically suicidal, severely suicidal, needing high doses and lots of treatment to just keep them alive, basically. But SI continues to improve all the way through 20 sessions. Mood, still, generally, like we said, pretty persistent. Energy, and basically you get this like plateau level where like, it's great because insurance continues to cover it because they're coming in every time at about quids of 10. And when they get better, we actually have to argue that we're keeping them well instead of letting them get worse, et cetera, et cetera, et cetera. Thanks, everybody. Looking forward to the panel and the questions. All right. Let's do it.
So one of the things that we were really excited about with being able to put together this conversation was that you can get a relatively quick sense from the last 40 minutes about there are some things that appear to be relatively common in the clinical practices that you just heard about, and there's some pretty stark differences in some of the practices that you just heard about. And I think Mike's ability to share about what MGB is doing, you have to remember that's a tertiary care center. So your facility is significantly more resourced than most outpatient communities. You have the ability to do things in office that many community clinics don't. And at the same time, their patient population tends to be a lot sicker, for lack of a better term, than most. So do think about the fact that who you're working with patient-wise can be some of the explanation for why there's such a big difference in these community practices. With that, there's some questions, so we'll open it up.
Great presentation, thanks. Could you describe your criteria and procedures for intervening for tachycardia?
Me? Or anyone? I mean, I guess it'd probably be more related to you. So it's about when we would intervene for tachycardia specifically. We don't particularly intervene for tachycardia. Maybe with our S-ketamine patients, we would give propranolol if their tachycardia looks pretty bad. But for the IV patients, we're looking at blood pressure primarily. I mean, they kind of go hand in hand. That's one reason why we use labetalol. And labetalol does seem to be like relatively perfect for esketamine, given its like adrenergic nature on alpha receptors and things like that. So it works really well. Obviously, you need to be like continuously monitored, basically, in most places. You guys cannot do that, and we can't even really do it. We just monitor very, very closely, like every few minutes, and trend it very. Whenever we're using it, we're going to trend it very, quickly every 5 minutes or so until it starts going down.
Similar thing for us. We wouldn't treat the number. We'd be looking for, are there other things that we're concerned about in conjunction with that tachycardia? Is that a signal for something else going on? And if the number decreases on its own after the infusion, or if we're not getting other indications of some sort of systematic issue, we would let the number be and only treat it if we start to have an underlying root cause of the tachycardia.
How much does route of administration impact the safety profile?
Oh, I mean, IV, certainly you get everything that you put in, and so I find it a lot easier to use, to be quite frank. We have not really done much IM, intranasal, racemic ketamine, not as much either, but those things are more highly variable, and I think the advantage of IV is that you can administer other things, you can slow down the infusion, you can even give it over 60 minutes if you prefer, these sorts of things. So it's probably the safest route because it can be turned off, whereas with even Spravato, we've noticed that some patients, like having panic attacks, you can't do anything. Chew on an Ativan, I mean, it's really, really quite challenging in those situations.
On this note, I think one of the things you're seeing from what we just talked about now is that even for IV, these situations are pretty rare. And I would say to the audience at large, exert some caution that just because we haven't had good published reports of adverse events with oral doesn't mean that they're not there. It just means that we may not have actually collected them and studied them and put them under publication for outcomes there. There's a whole framework for oral, and to be clear, I'm not speaking out against oral more broadly. I'm just trying to frame the context of what's going on here. Remember, IV doses you just saw, we average 40, 50 milligrams of ketamine. And a lot of adverse events are a consequence of the total body load of the drug. So if these patients are taking oral and needing to take 5x the amount of ketamine to get the same amount of the blood-brain barrier, well, their body's exposed to 5x of the drug, their kidneys are exposed to 5x of the drug, their livers are exposed to 5x of the drug. Much less if you get to some of these at-home companies that will ship you a gram of ketamine to take all at once. That's a 20-fold increased dose. And side effects, generally speaking, for most pharmacology, are total load dependent. So there's a real framework here that actually oral could, if we have better data on this, be a lot more side effect prone, a lot riskier. We need some better published studies on that, but don't take the absence of data as the safety indication. Take it as there's something we need to understand better before we start making strong statements about it.
Yeah, that's an excellent point, and it's a point I make a lot too, especially with regards to metabolites in the bladder and so on and so forth, right? I think you answered this, but it was interesting to see the need for a more aggressive dose escalation in the MGH versus Ember induction procedures. What might explain this difference? I mean, maybe you can comment.
We talk about this all the time.
Yeah, more aggressive escalation. Mm-hmm. Maybe the population that often we do have a lot of recently discharged folks. A lot of people who just for the wait list, a 2 to 3 week wait list, seem to be getting a lot worse. So, for 2 to 3 more weeks to go by without being more aggressive, we just have found that people seem to need more anyway. And once they do really well at the 5th, 6th, we can back off for a few treatments, or we can always lower it. But we're aggressive, just want to see an effect.
Mm-hmm. That's what I figured, yeah.
Yeah, absolutely.
When you say PTSD, substance use disorder comorbidities had accelerated response, this is about time to improvement, not final score differences, correct?
Ben, that's you.
It was with respect to a more rapid reduction in symptoms over time, correct?
Okay, yeah, so we'll take a break here.
Yep.
I'm downstairs.
We got
I have a question about seizures. In the literature, it seems to list seizures as a risk factor to ketamine, yet I've been instructed and intubated and RSI'd many status epilepticus patients, and they've been advised to use ketamine. I searched the literature, found one case of a pediatric seizure that they thought might be due to it. In my first year of practice, I had a patient seize in the chair, but found out that they stopped their scheduled benzodiazepine against my advice 2 days earlier, and that was the obvious cause. But does ketamine cause seizures? It's listed as side effects in a lot of the literature.
So,
I can't find it.
I've been looking for this for a long time. Basically because anyone who can't, with seizure disorder, can't get TMS, so they come to ketamine, and Often, out of an abundance of caution, we get their neurologists to like clear them, or at least get an understanding that we're doing this. But the fact that ketamine is used to stop seizures, stop status epilepticus, is an adjunct to like delirium tremens and seizures for alcohol withdrawal. I mean, I am just not convinced. We've also done plenty of motor threshold treatments to like look specifically at whether or not ketamine has been acts on seizure threshold. The variability is more between providers than it is between the biology of the patient. Quite frankly, like I am not particularly intimidated by it. I just don't. But we are in a hospital setting where if they did have a seizure, we'd very quickly give IV Ativan and we'd call them to go to the ED. But that has not happened, right? And we've had 20,000 infusions.
I'll echo the one thing to be conscious of for this patient population is a lot of them are on benzos. And so we've also similarly had a seizure, not in office, thankfully, but the day after, somebody who had to stay in the ICU for a week for epilepticus because they'd self-discontinued their benzos despite that being our advice. So even if it's not a direct effect of the ketamine, be aware that the group you're working with have a predisposition for seizures, particularly those who are on benzos and not necessarily taking them as advice.
Especially because we talk to them about it affecting the
Correct.
efficacy, and sometimes they'll go over. So it's important
Yeah.
to say, but we don't think you should stop it.
No, I mean, I definitely want to emphasize that, we have not for years thought that benzos really impacted at all. We've always seen it as like facilitating tolerance treatment. Like if you cannot give someone more than 0.7 and their depression is only getting better for a day and you give them a milligram of Ativan, now you can get them up to 1.5. We've been in support of that because we've seen them get so much better at 1.5 mg per kg. And then now the data is starting to bear it out that was probably like a little too sweeping of a judgment before. I mean, the fact that Nico's data really bears out that like they're iller because they've got comorbid anxiety to start with. They responded almost the same exact rate, and then they're iller at the end because they've got residual anxiety symptoms. It does not mean that the benzos attenuated it at all. And quite frankly, I think it's something that needs to be revisited. Not encouraging everyone to use IV benzos unnecessarily. If you can do a one-to-one, clinician to patient circumstance where you can calm them down all you want. I mean, frequently if they start getting anxious, we will run in there. But the discussions were like, okay, calm down, you're in the ketamine clinic, all right, give them an Ativan, let's go.
Slightly different process.
All right, thank you guys. We do have 2 more very important presentations and then closing. So please come back here at 4:40.
Yeah, appreciate it.
Thank you all.